Everyone. Great. Good morning. I have the pleasure of welcoming you all to this call today. And before we dig into the clinical and epi details, I want you all to know how much we appreciate your partnership. As we have weathered the storms of the pandemic, each of your programs continued on the front lines to meet the holistic needs of your patients and your communities. And it cannot go unsaid that you have never wavered from this commitment, even through times of political and financial stress. So on top of this work, we are now requesting your further partnership and cooperation during this new outbreak of the monkeypox virus to ensure the health and the safety of all Granite Staters. Here at the Division of Public Health Services, we are approaching monkeypox with the urgency that it deserves. And we need your help to center equity and access in this work, ensuring that we meet people where they are, wherever they are in this state, in a way that is respectful. I don't have to remind the folks on this call about the complexities of the relationships between LGBT communities and healthcare and the government, and all of you are ambassadors of goodwill and good medicine, and we need your help at this moment. While you are meeting patients where they are, we at DPHS have been following CDC guidance to process specimens in our public health lab, monitor contacts of known patients, and identify any new infected people in our state, all while building some capacity to respond quickly to prevent the potential spread of the virus. And this is where we most clearly need your partnership. We believe that your health centers are uniquely positioned to recognize and test for monkeypox virus infection. This is part and parcel of the reproductive and sexual health education and treatment that you all do every day. We also want to share information about where we are with vaccine and discuss potential options for vaccinating high-risk populations. This is where we continue to need your feedback as well to make sure that we get our planning right. Today, you're going to hear from Dr. Chan and Dr. Talbot and from others from DPHS about the epi and clinical details. And I hope that you've come prepared with questions. Please also feel free to share any information or feedback that we should be considering as we continue to do our joint planning together. As always, you have my sincere appreciation, and I'm indebted to all the advocates and educators and community and healthcare partners who are working to keep New Hampshire residents safe and healthy, especially in these really complicated times. So we need you more than ever. And with that, I'm going to hand it over to Dr. Chan. So thank you so much and welcome to this webinar. We hope that it is informative for you.
Great, thank you so much, Trish and Steph. So hopefully you can all see my slides in PowerPoint presentation mode. I have the task to start us off today by talking about three topics: epidemiology, some clinical background, and then talking very briefly about medical countermeasures. However, before I jump into that, I actually wanted to start with a couple of slides, which I think are two of the more important slides of what I have to talk about in this section, which is the goals of the public health response and who is at risk, who do we need to target services to. And so I just want to call out up front that there are two general goals right now in the public health response, both in New Hampshire and nationally, right? One is containment and one is prevention. Monkeypox is not a disease that is normally circulating or occurring in the United States or many other parts of the globe. And so there is still a desire and a recognition that this could be a containable disease. So elimination, right? So when I talk about containment, I'm talking about responding to an identified infection. And in order to identify infection, we need to have the ability to test and confirm people with monkeypox. That leads to case investigation and contact tracing, isolation of people that are infected, and then monitoring for people that have been exposed, right? We're not quarantining people who have been exposed, but we're doing active monitoring to monitor for symptoms so that we can connect them with care. And then importantly, we have the Jynneos vaccine for post-exposure prophylaxis. if this vaccine is given within 4 days from the date of last exposure, it can prevent disease, prevent occurrence of disease. If it's given between days 4 and 14 after an exposure, the vaccine may reduce symptoms, but likely will not fully prevent disease, right? So we have a number of tools in our toolkit to try and contain this new emerging infectious disease. When I say new emerging, I'm talking about emerging in the United States and other places where it's typically non-endemic, right? This containment approach is not unlike what we have attempted and occasionally do with other diseases. But I want to be clear that this approach is not going to stop transmission of monkeypox in and of itself. We're seeing this occur now with the increasing circulation, increasing transmission of monkeypox. Simply testing and identifying people and isolating them and doing contact tracing is not sufficient to stop the spread of monkeypox. We'll go into a little bit more why that's the case. And so there is also the goal of preventing monkeypox in the first place, both through awareness and risk reduction counseling. But importantly, the Jynneos vaccine can be used for pre-exposure prophylaxis, particularly for people that are at risk or at highest risk for monkeypox. And this is where a true pre-exposure prophylaxis or PrEP vaccination strategy will be important in order to fully contain and control and stop the spread of monkeypox. Now, I'm sort of separating these 2 points out because we're currently and actively engaged in the containment approach, knowing that we're trying to limit the spread, but it will not fully control or stop the spread of monkeypox. And that is a temporizing measure until we get sufficient vaccine supply where we can truly roll out a pre-exposure prophylaxis approach to vaccines. Now, the question is, well, when is that going to happen? When are we going to have sufficient vaccine supply where we can more broadly vaccinate people at risk? And the answer to that is we don't know. It's likely going to be months, likely into next year. And how far beyond that we're out there vaccinating people to prevent monkeypox remains uncertain. Part of the reason is that this is not a vaccine that is commercially available. This is a vaccine that has been developed and purchased through the federal government as part of the strategic national stockpile. And so it's not a vaccine that has been in great supply. And now that we are in the situation we find ourselves in, there are moves to manufacture more, but that takes time. And when we have more supply, we will be looking at using the Jynneos vaccine as the primary means that we have to stop the spread of monkeypox. But that is going to be months in the process. Now, the question is, who is at highest risk for monkeypox? And we'll talk more about transmission in a little bit, but let me just say that these are sort of the 3 categories of people who we would determine to be at highest risk for monkeypox. So number 1, people who have any close prolonged contact or any direct physical contact to another person who has monkeypox, and with a caveat of people without wearing appropriate PPE. When I talk about close prolonged contact, I'm talking about being in the same shared airspace, being in close physical proximity to somebody on the order of hours, right? This is not as easily transmissible as COVID-19. This close prolonged contact indicates, being face-to-face with somebody, driving in the same car, for example, living in the same house or in the same room for a period of hours. And so the main mode of transmission is really going to be direct physical contact to another person with monkeypox. We also know that this virus can survive for a prolonged period of time, days and weeks on physical surfaces. And so any person that comes into contact with items like clothing or linens that previously touched an infectious rash or infectious body fluids of a person with monkeypox without wearing appropriate PPE is considered at risk for monkeypox. And then people who engage in high-risk sexual activity, including people who have multiple recent sex partners, people who engage in group or anonymous sex, people who exchange sex for money, drugs, or other services, people who engage in sex with others identified through dating apps or bathhouses or saunas or other sex on-premise venues, and even people who have a sex partner who engages in higher risk sexual activity. Now, you'll notice here that I didn't specifically list people who are gay, bisexual, or men who have sex with men as specifically the specific highest risk factor. And while monkeypox is primarily circulating amongst this group, anybody who engages in high risk sexual activity, anybody who has close physical contact with another person with monkeypox is at risk. And so right now, while monkeypox is primarily circulating and transmitting through sexual networks in people who are gay, bisexual, or in men who have sex with men, it is not going to be limited to that group in the future as monkeypox increases in circulation. And so we really have our sights set on identifying who the highest risk populations are based on some of these factors listed here. All right, so those are, I think, some of the more important comments that I had. Let me give very quickly some brief background on monkeypox and some epidemiology. As I alluded to, case counts are increasing in the US and globally. Transmission is occurring largely through sexual networks. The outbreaks we're seeing are predominantly affecting younger males who identify as gay, bisexual, or MSM, but the risk is not confined to that group alone. Mostly what we're seeing is mild disease, and there have been no deaths from monkeypox reported in these outbreaks that are occurring in non-endemic countries. Now, this is a global map taken off the CDC website yesterday, showing the burden of disease so far in 2022 globally. The orange circles represent the burden of monkeypox in areas not historically reported to have monkeypox. And so far this year, there's over 14,000 cases from 64 countries where monkeypox is not normally endemic or not normally circulating. The blue dots, as you can see in Western and Central Africa, are where monkeypox has been reported historically, where it is considered endemic. You can see so far 243 cases from 6 countries. So this gives you an idea about the global burden of monkeypox. Again, over 14,000 cases so far, with the majority of infections being in European countries, the UK, and the United States. Here's a graph looking at the cumulative case count over time. Spain is #1 globally in terms of case count. United States and the United Kingdom are bouncing back and forth, but and then I have Canada down there as a comparison. You can see the trajectory here in the United States of cases is more on par with what's being seen in Spain than what's being seen in some other countries like the UK or Canada. So given the increasing transmission, the increasing spread of monkeypox, we're going to see more cases in the coming weeks and months. We're going to see more requests for testing. We're going to see more diagnoses. And in fact, when you look at the US as a whole, I think about 45 or so states and territories across the country have identified monkeypox at this point. There's over 2,300 cases. New Hampshire has 3 cases identified so far. And the requests for testing, the suspicion for monkeypox cases is only increasing. And so again, over the coming weeks and months, we're only going to see the number of diagnoses increase. Let me talk very briefly about some of the clinical features and medical countermeasures. Some of this I believe most of you are probably already aware of. There are 3 what we consider stages of monkeypox. There's the incubation period, where a person is not considered contagious, meaning they're not considered infectious while they are asymptomatic. After an exposure, the average incubation period is typically about 7 to 14 days, but can range up to 21 days. There is oftentimes a prodrome period where people develop non-specific symptoms of fever, chills, malaise, muscle aches, headaches. Sometimes people can develop upper respiratory symptoms like a sore throat and a cough. And then lymphadenopathy is a feature of monkeypox that may not be seen with other diseases. The CDC reports on their website that a person may be contagious during this period. I do want to be clear, though, that not everybody develops prodromal symptoms before onset of the rash. The rash typically progresses, the monkeypox rash that is, typically progresses through 4 stages. There's a macular, then a papular, vesicular, and a pustular stage. A person is considered highly contagious from the onset of the rash through the scab stage. Now, prototypically or historically, the rash has been reported to progress from the mouth to the face to the arms and legs. That includes the hands and feet and palms and soles, sort of going from a central distribution outward. However, during the 2022 outbreaks, the skin lesions have presented in a more atypical presentation than what has historically been reported. Oftentimes, the rash is of a more limited distribution. Skin lesions have been occurring in isolated areas of the genital and perianal areas, which likely indicates the site of inoculation. So just be aware that when you look at the description of the typical monkeypox rash, there is sort of historically what has been seen, and that may differ from what how the skin lesions present during the 2022 outbreaks. A person is no longer considered infectious once all skin lesions have scabbed over, the scabs have fallen off, and there's a fresh layer of new skin. This can take 2 to 4 weeks, which is a lengthy period of time for people to be potentially infectious. The typical monkeypox skin lesions are described as well-circumscribed, deep-seated, and oftentimes umbilicated, which is seen in the pictures in the upper right-hand corner here. These are all, or most of these pictures that I'm showing are actually photos that have been taken during these most recent outbreaks of monkeypox. But you can see that these are not blisters. These are oftentimes not simply folliculitis. Again, deep-seated, well-circumscribed, often with umbilication. And actually, one of the common symptoms of these is pain. And these lesions oftentimes are painful. They can cause scarring. And so the rash lesions alone can cause significant morbidity. Exposure occurs through broken skin, through the respiratory tract, through mucous membranes. As I mentioned earlier, this requires close, prolonged face-to-face contact through the spread of large respiratory droplets, direct physical contact with infectious body fluids or lesion material, or indirect physical contact with infectious lesions, infectious lesion material or fluids that have contaminated clothing or linens. Monkeypox is not considered a sexually transmitted infection at this point. The belief is that the spread is occurring through sexual partners or between sexual partners through physical contact, but certainly it remains possible that monkeypox could be sexually transmitted, but this is undergoing and needs further study. Just as an example, here are all the various body fluids and specimens where monkeypox has been detected by PCR. You can see saliva, semen, rectal swabs are on here. These are specimens that have tested positive for monkeypox by PCR. Now, the risk of transmission through these routes is unclear because PCR detection does not necessarily mean that someone is infectious or those body fluids are infectious. And just as an example, there was one study at least of 2 German patients who had monkeypox virus detected in semen by PCR, but when they went to try and culture it, there was no growth in viral culture. And so it remains uncertain what the transmissibility is of the monkeypox virus through these various routes or fluids. I know that we have a largely healthcare audience on this call. I want to acknowledge that, and this will be talked about later, regarding personal protective equipment. There is always concern for protecting the healthcare workforce. I want to point to this article that was recently published a few weeks ago that looked at historical literature on monkeypox transmission in healthcare facilities. And based on the literature, the authors conclude that in summary, based on published reports prior to May 2022, global outbreaks of monkeypox, looking at global outbreaks of monkeypox in non-endemic countries, the risk of exposure in well-resourced healthcare settings leading to transmission is low, with only a single reported transmission event in the current literature. And that was in somebody who they suspect the route of transmission may have been through handling bed sheets and bed linens after a person with monkeypox had contaminated some healthcare services. And so despite hundreds of healthcare contacts, there have been very limited very few episodes of transmission to the healthcare workforce. And so monkeypox, again, I want to emphasize, is not easily transmitted without close, prolonged face-to-face or physical contact. So for our healthcare providers, when evaluating a patient for monkeypox, and others are going to go into a little more detail about this in a few minutes. Here are the CDC recommendations. Place the patient in a private room, ideally with a private bathroom. Airborne isolation is not required unless conducting an aerosol generating procedure. Wear recommended PPE. Take a detailed sexual history. Again, monkeypox right now is primarily transmitting through sexual networks, so a detailed sexual history is important. Ask about any close contacts a person may have had with another person with similar skin lesions. Take a detailed history of the skin or skin rash or lesions and any other symptoms. And then importantly, which helps us out, please ask about sexual, household, or other close contacts since the rash began or since symptoms began, because that's going to impact who we need to reach out to connect them with post-exposure prophylaxis for connecting them with, to prevent them from getting monkeypox. We do recommend testing people with skin lesions that are consistent with monkeypox, especially if skin lesions are on the genital or perianal areas, or if a person has any identified risk factors. We also recommend screening for other STIs, even chlamydia, gonorrhea, syphilis, given the high risk of concurrent infection. There was one study out of the UK from a sexual health clinic, which showed that at least one in four people with monkeypox at that clinic had either a chlamydia or a gonorrhea infection. And then please report any suspected cases of monkeypox to New Hampshire Public Health. The number is listed here, and this is the same number that can be found in all of the HANs we send out. And then finally, I just very briefly want to mention, this is my last slide. There are treatments for monkeypox. Vaccinia, immune globulins, cidofovir, brincidofovir, those are not the primary treatments that are being reached for right now. TPOX or tecovirimat is the drug that is primarily being looked to if somebody needs treatment for monkeypox. TPOX is an antiviral drug that was approved for treatment of smallpox, right, a related orthopox virus, approved for the treatment of smallpox in adults and children. Its use for monkeypox is covered by a CDC expanded access investigational new drug protocol or IND protocol. This is available in oral capsule formula or through in IV vials. But I want to be clear, there's no or very limited human data available on the effectiveness of treating monkeypox virus in humans with TPOX. It is available though. It requires a CDC consultation to obtain and use TPOX, and there are IND requirements that need to be followed, which are outlined in this link I list here. And then there are a number of people that we would consider treatment for. Certainly those with severe disease, that's primarily who we've messaged targeting monkeypox to, as well as people who are at high risk for severe disease. And then CDC has this third recommendation, people with aberrant infections involving accidental implantation of infection into anatomic areas where monkeypox virus might constitute a special hazard. It's not entirely clear what's intended by this category. They list the eyes, certainly. If somebody has infection in the eyes, that might be an indication. But they also list other sources or other sites of inoculation, like in the mouth or the genital area, which would apply to most people during these outbreaks. But we're not typically recommending reaching for TPOX to treat all genital infections. And so I think under certain circumstances, certainly if there is an aberrant infection or inoculation identified, it could be considered. But otherwise, we're looking to use monkeypox for those with severe disease or at high risk for severe disease or complications of monkeypox infection. So with that, let me actually end. I've gone a little bit over my time. I apologize, and then hand it over to our next presenter. Thanks.
Thank you, Dr. Chan. Hello, everybody. So I am Megan Hetty, the Section Chief of IDPICS, the Infectious Disease Prevention, Investigation, and Care Services section, and I will be covering how to safely and efficiently test for monkeypox. We can move on to the next slide. So the first thing I want to cover for our testing is there are two main pathways for testing. We have our New Hampshire Public Health Lab, and we do have some commercial laboratories. So to focus on the public health lab, all testing that goes through us in the public health lab does need to be coordinated through DPHS. Some of the information I will cover in kind of detail to collect and communicate with us. We do ask that certain criteria is met so that testing can be done at public health lab. And I will go into more information about what that criteria would entail. Part of it is that providers also must ensure that there is a specimen submitted appropriately so that it is contained, it is proper lab requisition forms, and so that we're able to efficiently and quickly test without any delays. And in addition, we do need that coordination with DPHS to have that coordination with Public Health Lab so that we don't have any unnecessary delays while trying to figure out what specimens came from which facility or any concerns about who the specimen belongs to, things of that nature. So to reinforce, please don't send any specimens to New Hampshire Public Health Lab prior to contacting us in that Bureau of Infectious Disease Control. Additionally, we do have commercial laboratories online. So testing is available at 5 locations, and this is to expand testing capacity nationwide and making testing convenient and accessible so that you don't have to go through us. Because you may not need to use us for coordination of testing, and you can absolutely submit directly to commercial laboratories, we do ask that you report any suspected cases to us so that we can be prepared to assist with any quick response if that specimen is later identified as positive. Next slide. So for which commercial labs are available, we do have the 5 listed here. I will note that of these 5 here, the Aegis and the Sonic Healthcare are reported to us via eFax, and our LabCorp, any Mayo Clinic, and Quest Diagnostics can come through us through ELR. So all these 5 here are available for use. I will say that LabCorp and Quest Diagnostics seems to be the most that we use within the state, and that's exactly why we have ELR onboarded for them. But if you do use any additional labs, for example, that Sonic Healthcare, we do have a mechanism identified to ensure prompt reporting for those that don't have that established ELR. Next slide. All right, so if you do request testing in Public Health Lab, and if you suspect monkeypox, we do ask for the following information that we have on this slide and the next slide, and have a provider collect this information before contacting us. Now, this information really helps us get a better clinical picture of what's going on with the potential case. Everything that we collect is pretty much what Dr. Chan just covered. We look for kind of demographic information like age, sex, and gender. And then we look for detailed information about any symptoms. So we look for any kind of prodrome, the onset date, a very detailed description of the rash that includes things from onset date to which body parts are affected, the number of lesions, the description of lesions, the size of them, how many we have as macules versus papules, how many are pustular, any kind of characteristics that we can find about that rash to help us get a better understanding of testing needs. Additionally, we do ask to collect some risk factors, and some of these risk factors include the ones that Dr. Chan just covered, but it's contact with anybody who's had a similar appearing rash, any contact with another person who's suspected or confirmed with monkeypox. Those 2 may just be our main pieces of, yes, of course, that is a risk factor. Others include any travel to a country with confirmed cases or to any of the endemic countries, and that's in West or Central Africa. Any rash that has any kind of lesions develop after intimate or sexual contact, any MSM history, any intimate sexual contact that occurred during travel, and basically any other high-risk sexual contact or behaviors. So some of that includes multiple sex partners, anonymous sex partners, etc. And then we have this last piece here on the bottom is any contact with dead or wild exotic animals of those endemic species in Africa. We're not really seeing this during this outbreak, but that is one of the risk factors that has been identified for monkeypox in general. Next slide. So if you have that core information, that is what we need to truly get a good sense of if testing is going to be required through Public Health Lab. The additional information I have here is very nice to know and would be greatly of a benefit to us to be able to have a public health response for this individual. So knowing if that individual is isolated after they presented to any kind of clinics, and they're isolating from the time of swabbing and testing until we have notification of results. Any healthcare visits or exposures during the time they have symptoms, that helps us also identify any healthcare related exposures. And having a sense of how many household contacts, how many people are living with this individual, any sexual contacts, those would really help us identify and prepare for any post-exposure prophylaxis and be better responsive if the results do come back positive. We also have information about any additional tests being performed. We'll get to that in just a few slides, but just so we have any other understanding of additional clinical diagnoses that are under consideration. And next slide. So if you collected all this information, you still think you have someone with a suspect for monkeypox, we do ask then you to call us at our main number here, which is that 603-271-4496 to contact with a public health professional. We are available at this number Monday through Friday from 8 to 4:30, and we do have availability after hours. So you can call 271-5300 for any time after 4:30 to 8 a.m. We always have someone available to have any discussions. If you have any questions about testing, if you're unsure if testing needs to be met, or you do need to collaborate with us to have public health lab test, any of those numbers are available for you to contact. We would ask all the information that I just went over to be collected and to discuss to determine if that testing criteria has been met. And if testing is recommended, that individual that you call will give further information on steps for specimen collection, if you have not already done so, and how to transport that specimen to public health lab. As a note, once the specimen is at the public health lab, that's where we conduct initial testing for orthopox. If it results as positive, we do proceed with further contact tracing and any kind of identification for medical countermeasures, but we do send that sample to CDC to perform characterization testing as well. So we will get a positive orthopox and we will treat a positive orthopox as if they are positive for monkeypox. Next slide. All right, so specimen collection. We have information and all of this written out in our HAN from May 20th, and we also have a public health lab collection kit instructions for additional information. But for a very kind of clear visual here of what it needs for testing, you can have up to 2 lesion sites swabbed. There will be 2 swabs and 2 storage containers and 1 lab requisition form for each lesion site being tested. If you are only able to swab one area, so let's just say there's only lesions in the genital area, you only have to submit 2 swabs. If you have lesions that are on the hands and let's just say the feet, then you can submit up to 4 total specimens here, indicating the 2 different locations that you have swabbed. So biggest factor here that we have to remember is those 2 swabs will be used at the same time on that lesion site. So you can see in the picture here that there's 2 swabs. So 1 and 2 will swab that arm there. Once that lesion has been swabbed, they will be placed into 2 separate containers, but bagged into 1 bag with the lab requisition form to make sure we highlight the name of the patient, identifying factors like date of birth, the location that site was swabbed, and any kind of medical record number. And that medical record number, the name, the date of birth, whatever that ends up being put on that for specimen labels does need to match that lab requisition form. Now, if you have another location, you could do the same thing. So that'd be swabs 3 and 4. You would swab another location. They would go into 2 separate tubes and into a separate bag together to indicate that this is site B that is being tested. So A, B, 1, 2, you can be able to differentiate what we have available for testing. I also want to highlight that we do not want to use any transportation or any kind of media in the tubes. So if you have a tube, if you have any kind of sterile container, as long as that swab is able to fit into that container, that is all that is needed. So no media, nothing, any kind of liquids or forms in that. It basically needs to be a dry swab in a sterile container. And we want to make sure that that container is able to, one, contain the swab and not pop open any lids and cause unnecessary exposure within the bag. But we also want to remember that we do need to refrigerate specimens within an hour after collection. So preparation would be really great if you go in, plan for testing, making sure that you have swabs that fit into appropriate containers, you have enough containers available, and you're able to immediately refrigerate that specimen if you're coordinating with us for testing, or if you're coordinating with any other commercial labs before that is transported out. And last but not least, all those bags, whether you have one bag with 2 swabs or 2 bags with 4 swabs, they will all need to go into a single kind of shipping container that will need to be boxed up with an ice pack to maintain that appropriate temperature in transit. And next slide. So going over the testing piece of it, the other thing we need to consider is infection control during that specimen collection. So how do we best protect our healthcare workers collecting that? So any personnel who collects specimens should use personal protective equipment that is in accordance with the recommendations for healthcare settings. So this includes a gown, gloves, eye protection, and that's either goggles or a face shield, and any approved particulate respirator equipped with an N95 filter or higher. This is what we definitely recommend, especially if you have a swab that doesn't have any, or sorry, a rash that doesn't have any kind of either fluids coming out, pus, anything like that, and you're doing a little bit more of a rougher swab and potentially exposing any kind of particles up from the skin. Next slide. So just covered any kind of infection control when testing, but we do want to also remember that infection control in general is good to remember here. So like Dr. Chan said, the transmission in healthcare settings has been rarely documented. We do have our basic guidelines for isolation precautions that can be accessed here. I believe many of y'all will be very familiar with this, and some of the basically standard precautions that we would want is, again, using standard precautions. If you have a patient that is seeking care and suspected to have monkeypox, any infection prevention and control personnel should be notified so that we're able to adequately prepare for where that individual should go, but also how to clean that room after. So any activities we would coordinate to be like that would resuspend any dried material. So we would look at avoiding any kind of fans, any dusting, sweeping, or vacuuming, just so that we're not spreading any particulates into the air. And any decisions related to discontinuing isolation with precautions in a healthcare facility should be made in consultation with us. So if you have somebody who is in a hospital setting or has been admitted, that's where we would want to have that coordination before they are released. And so we can make sure that there is a appropriate infection control for cleaning that room. Next slide. This is the same slide that Dr. Chan went over. Again, best practices on patient placement, how we would want to handle any suspected or confirmed monkeypox infections. So I won't go into super detail of this one, except for the second from the bottom, is if a patient is transported outside of their room, we would recommend that they use a well-fitting source control, like a medical mask, and have any exposed lesions covered with a sheet or gown. And so having that respiratory piece covered, having any lesions covered, they would be able to move outside their room or facility. And then last but not least, intubation and extubation is something we would look for, but I believe in majority of these settings, we would not have to worry about that. Next slide. More information on environmental control. So standard cleaning and disinfection procedures should be performed using hospital grade disinfectant. And we do want to have a bit more attention to detail when we are managing soiled laundry. So just like we were talking about with transmission and any scabs or particulates, any soiled laundry should be handled in accordance with standard practices. And we want to avoid any touching any soiled laundry that has come in contact with any lesions. So any laundry should be gently and properly contained in an appropriate laundry bag. We don't want them to be shaken out. We don't want it to be roughly handled that may disperse any of that infectious material into the air, especially if someone's working with that and have that potential exposure. And the same thing, we want to avoid when cleaning the room, any dry dusting, sweeping, or vacuuming, and any wet cleaning methods are preferred for infection control. Next slide. And to wrap everything up, we want to focus on any additional testing to consider. So this rash is associated with monkeypox can also be confused with other rashes that are encountered in your practices. So that could be herpes, syphilis, or varicella. So it is important to really evaluate that patient that is presenting with similar rashes and to have any additional testing formed. So not only thinking about herpes or syphilis or varicella, we do want to screen for additional STIs that are not associated with skin lesions, since they are presenting for care and should also be considered. I do want to note that co-infections with monkeypox and STIs have been reported, and the presence of an STI does not rule out monkeypox. So an observation from a clinic in the UK found that 1 in 4 people had concurrent STIs while they were positive for monkeypox. So it's something that if they're presenting, we definitely want to use that opportunity to test for other STIs while also considering that monkeypox may be the reason for the rash. And with that, I believe I am switching it over to Paula.
Thanks, Megan. Paula, when you're ready, we'll turn things over to you for the vaccine access and implementation update here in New Hampshire.
Absolutely. So my name is Paula Holligan, and I am the program manager for the immunization section. Next slide, please. And first, I just want to mention that I know we do have a hard stop at 11 a.m., so I will shorten some of these slides. But also, if you have any other questions at all after this presentation, feel free to reach out. There will be some contact information at the end. So in regard to vaccines, Jynneos and ACAM2000 are the 2 currently licensed vaccines in the United States to prevent smallpox. Jynneos is also licensed specifically to prevent the monkeypox virus. So New Hampshire has chosen Jynneos as the preferred vaccine to administer to individuals due to the provider familiarity with administering this vaccine subcutaneously and its ease of use. So Jynneos is a 2-dose series. It's a non-replicating live virus vaccine and will be requested by the state if vaccination is indicated for an individual. With the Jynneos vaccine, the vaccinator should use universal precautions during administration. Currently, there are no plans to use the ACAM2000 in New Hampshire, and basically that is due to several challenges with the vaccine administration. It requires specialized training because it does require a bifurcated needle. ACAM2000 has an extensive contraindication list, as you can see here, and there are some safety requirements we need to consider for both the vaccinator and also the vaccine recipient. And next slide, please. I'm going to actually skip this. Basically, this is just talking about a couple of different things. I believe that this is covered with some of the other areas that Megan and also Ben covered. So we'll go to the next slide. So in regard to the National Vaccine Strategy, Jynneos is recommended by the Advisory Committee on Immunization Practices for what we call pre-exposure prophylaxis, which is PrEP, post-exposure prophylaxis, which is PEP, and PEP++. You may have heard this also as expanded PEP or also community PEP. So this is for against orthopox virus infections in individuals of age 18 and older. So PrEP was originally had been indicated for individuals who were at risk from healthcare occupational exposures, but the guidance was recently updated to include vaccinating individuals that were deemed to be in a high-risk category. Currently, most clinicians and laboratorians who do not perform the orthopox virus testing are not recommended to receive the PrEP vaccination. In New Hampshire, the only PrEP vaccination that we have done so far is with laboratory workers. So far, the majority of the monkeypox cases and globally have been within MSM, as Ben had mentioned earlier, and we're looking at probably about high 90s percentage-wise. So beyond PrEP, the National Vaccine Strategy also recommends vaccinating individuals for PEP and also PEP++. PEP includes vaccinating individuals that may have been exposed to monkeypox virus and determined to be at high or intermediate risk per CDC guidelines. One of the strategies that the CDC recently presented for consideration is something called PEP++, and again, it's also looked at as expanded PEP. And with PEP++, individuals with certain risk factors are more likely to have been recently exposed to the monkeypox virus. So with PEP++, it aims to reach individuals post-exposure, even if they don't have a documented monkeypox virus exposure. So combined with self-isolation and other prevention measures discussed earlier, PEP++ can help slow the spread of disease in areas with large numbers of monkeypox cases. And next slide, please. In regard to New Hampshire's vaccine strategy, JYNNEOS vaccine is currently being distributed at a federal level based on monkeypox virus case counts, with the highest allocation going to states with the most cases. New Hampshire's current allocation of JYNNEOS is enough to vaccinate about 160 individuals with the 2-dose series mentioned earlier. The first use of the vaccine planned will be for PEP, and depending on the environment, what we'll either start out with is PEP++, if there are more cases that come along, or if there are increased prevalence of disease, or PrEP vaccination if cases remain low. For both of these instances, we need more doses allocated at a federal level though. Our current plan for JYNNEOS doses consists of PrEP, which will be used to vaccinate those in healthcare occupations deemed to be at high risk, and also PEP, which will be used on high and intermediate risk contacts identified in the CDC guidance. The federal government is ramping up to allocate approximately 1.9 million plus doses to states by the end of this year, and approximately 2.2 million doses to states in the first 6 months of 2023. For PEP++, our strategy is under discussion now and will be closely tied to future vaccine shipments. As mentioned earlier, we currently have hospitals lined up to assist with PEP and would like the sexual health clinics to possibly augment that effort depending on the size of a monkeypox virus outbreak. Next slide, please. So as we look forward to allocation and distribution plans to support PEP, PEP++, and PrEP, we'll be looking to you as clinics to help with vaccination for monkeypox virus vaccination. So sexual health clinics interested in participating in monkeypox virus vaccine clinics will need to sign a provider vaccination agreement to indicate agreement to maintain vaccine accountability. This agreement is to make sure that although the monkeypox virus vaccine is free, there are responsibilities such as proper storage and handling, temperature monitoring, and documentation of vaccine administration are held out. This agreement will be provided to you by the immunization program and will outline requirements and training for vaccine storage and handling, administration, and so on, as you can see here in this rollout slide. In the next few slides, I will go over the rest of these requirements. And next slide, please. So first is a medical order. So this is an important note. Your clinic will need to provide a medical orders in order to administer JYNNEOS. The standing orders for vaccination and emergency treatment in the event of anaphylaxis are not available from the department without a public health incident or declaration. And next slide, please. Also looking at equipment and other supplies to administer the vaccine. So we require cold storage and refrigerator and freezer to store the vaccine, a data logger to maintain temperatures that are recommended for the vaccine. And we understand that some clinics may not have this equipment. We are looking into various options, one of which is equipment loans to help in this area. Also, ancillary supplies are not included with the JYNNEOS vaccine. So supplies such as gloves, needles, etc., for the subcutaneous injection will be necessary to administer this vaccine. And next slide. Real briefly here, all rollout information that we have for a provider packet is listed here. Again, storage and handling guidelines, the BIS for the smallpox, monkeypox, JYNNEOS vaccine, how to record and consent file for that and document the vaccine, etc. You can see there's also an opt-out form here that's also included. So what we're going to do, just to let you know, is we will be providing these slides to you after. So if you have some questions, certainly you can reach out to us with the contact information at the end. And next slide, please. So as the vaccinating provider, your clinic will need to maintain a record of the patient's vaccine administration. In the short term, the immunization team can help with documenting the JYNNEOS vaccines in the New Hampshire IIS if the patient has chosen to share their information, in other words, to opt in. If a patient has chosen to opt out, the vaccine information will not be entered into New Hampshire IIS, but will be needed by the Department of Public Health Services if the individual is part of an infectious disease case investigation. If a continued vaccination response effort is needed, your clinic will later receive training in order to directly report into IIS. And next slide, please. So we need to understand your clinic's capacity to provide monkeypox vaccine based on the information presented here today. So here are some of the items that clinics willing to participate in this initiative need to consider. The provider agreement, medical direction, and equipment are items we discussed earlier in the presentation. The state is looking into how to support you in these efforts. In addition to deferring the NHIIS documentation, the department will assess your agency's needs to see if there's availability for assistance in procuring equipment. Unfortunately, we're not able to assist with ancillary vaccine supplies such as needles and syringes, et cetera. Another consideration is the provider agreement. So the COVID-19 immunization funding is not allowed to be used for monkeypox virus efforts. So clinics should follow their billing practices for a vaccine administration. While the vaccine administration fee is designed to cover your clinical costs, we also encourage you to look at other funding options, for example, a grant, to determine if the funding could assist in monkeypox vaccination efforts. And next slide, please. So this is the last slide. We want to partner with you to provide monkeypox virus, specifically PEP, PEP++, and PrEP vaccination, because we consider a partnership to be very important to us. We're interested in the feedback that you have today, including the concerns, barriers, or challenges that you see with the plan that we've presented here. If you're interested, we'll have an internal discussion to address open items that we're working on and any feedback that's presented here today, as well as some questions. What we'll do next after that is then communicate our vaccine strategy and plan to you and work with you to implement the vaccination plan. Thank you very much for your attendance here with this presentation. As you can see, my contact information is here. What you can do is email any of this information, questions, concerns, and feedback to that, and I will make sure it gets routed to the correct individual to get a response back to you. And I'll turn it back to you, Steph.
All right, thanks, Paula. Take just a second to highlight that the presentation that will be displayed online does have additional resources for your reference. At this time, I'm going to go ahead and stop screen sharing as we transition to the more interactive portion of this webinar. Just a quick reminder that you can enter questions into the Q&A function if you've not already done so. But before we transition to answering any questions, a Zoom poll will appear on your screen in just a second, and we invite you to provide feedback on your organization's capacity to offer both monkeypox virus testing and vaccine services. We encourage everyone that's attending today to participate in this poll and then to insert any questions that you may have as a result of today's presentation or other things that you've been wondering about, you could place into the Q&A function. While we wait for these poll results, I was just going to say, Dr. Chan, is there anything you'd like to add?
Well, so I was going to say there have been a few questions that have come in, a couple of questions about testing at the public health lab and cost that Dr. Talbot individually responded to, but I don't think everybody can see the responses that may have been typed. So I just wanted to verbally put out there that there is no cost for testing for monkeypox at our public health laboratory here in New Hampshire. There likely is a cost for testing at commercial labs. What that cost is I don't know. You would have to check with the individual labs, the individual commercial labs that are testing, but there is no cost for testing at the New Hampshire Public Health Laboratories. And then I wanted to give Katrina an opportunity to respond. I think she may have typed an answer already, but there was a question about, paper liners on the table and disinfecting wipes. And is there anything special that they need to do when cleaning a room? And Katrina, I know that you typed a response, but I think that's worthwhile maybe repeating verbally. Thanks.
Sure. Hi, everyone. Katrina Hansen, Infectious Disease Surveillance. So there's a question about paper liners and disinfectant wipes between patients. Just want to highlight that standard cleaning and disinfection procedures are sufficient as long as you use EPA registered disinfectant with emerging viral pathogen claim. And there was a link in the slide set, but I also put it here in the answer where you can find a link to all the different materials or that would fall under EPA. Wet cleaning is also preferred versus any type of dry dusting or dry cleaning. There are additional infection prevention materials as well on the CDC website. I believe that should answer the question, but happy to answer others as they come up.
All right, thanks, Katrina. Would any of our other panelists like to address any other questions or thoughts at this time? All right. Well, then I will turn to Dr. Chan for closing remarks and any last minute thoughts to share with the group. Dr. Chan, it's all yours.
Great, thank you. So not many questions came in. I'm not sure if that's a good thing or if you're still digesting all the information shared, but let me just reiterate, I think, what Director Tilley said in the beginning, which is we really appreciate you taking the time to be on this call amidst your busy schedules. We look to all of you at the local community level to be delivering these, primary care services to our residents of New Hampshire, and so very much value the partnership that we can develop. Monkeypox is going to be a challenge. It's a challenge now. It's going to be a challenge into the future, and a lot of the work that we're engaged in currently, both at public health and as providers in the community, really is testing and identifying infection, and then doing that, containment strategy, the contact tracing, the isolation, the monitoring. But as I mentioned in the beginning, that's not ultimately going to control spread of this virus long term. And so we really need, one, greater supply of the Jynneos vaccine, and two, we really need to partner with our community healthcare providers to be able to deliver this vaccine in the future when vaccine supply increases. So right now we're in the planning stages still of using what limited supply we have to target those at highest risk. We're starting with using the Jynneos vaccine for post-exposure prophylaxis. But as supply increases and we have more supply available, we will be looking at rolling out the Jynneos vaccine to those people that are at highest risk for monkeypox, likely starting with the MSM community and other people who identify as gay or bisexual and have some higher risk factors, particularly sexual risk factors, as I highlighted in the beginning. And so this is going to be an ongoing conversation, and I think that you will hear further outreach from us. We certainly welcome your feedback and your partnership, but we will need to move the Jynneos vaccine more into the community, vaccinating people who are at highest risk to get control of this infection. So really appreciate the time, really appreciate the partnership. Thank you for being on this call, and we certainly welcome any feedback you have. I also want to put a plug in to healthcare providers on this call to please join us on our regular monthly healthcare provider webinar that we continue to host. It's the second Thursday of each month. So the next call will be August 11th from noon to 1. The webinar information can be found online as well as in our Hans. And while this has been mainly a webinar that we use to convey COVID-related information, we are retasking it to address other emerging public health issues, including monkeypox. And so we'll have further updates for all of you on that call as well, on at least a monthly basis, but we will certainly reach out when there's more information to share. So let me thank you all once again. And with that, we're at 11 o'clock, and so we will end the call.